Hello everyone, welcome to Noble Psychiatric Services presentation. I'm Dr. Ondieki and I'm one of the guys behind Noble Psychiatry and Noble Pathway, and I'm excited to welcome you to this presentation about ADHD. I want to begin with one question. What happens when mental health challenges go unnoticed, misunderstood, or untreated? Every day we encounter individuals silently struggling with depression, anxiety, trauma, suicidality, and other psychiatric conditions, including what we're about to talk today, ADHD, that affect not only their mental health, but their families, relationships, and the quality of life. That is why this conversation is very important. Today, we'll explore a topic, ADHD, Attention Deficit Hyperactivity Disorder, in a practical, evidence-based, and clinically relevant way aimed at improving patient care and strengthening our approach as mental health professionals. Thank you for being here, and we will get started. This presentation is produced and designed by Noble Psychiatric Services. So this session talks about ADHD lifespan perspective oriented to psychiatry professionals who would need to gain diagnostic and management expertise. The objectives are to learn on the DSM diagnostic criteria for ADHD, its many clinical manifestation, and its neurodevelopmental basis. The discussion also incorporates the pharmacological and non-pharmacological approaches with the current evidence to maximize the results. The comorbidities are also paid attention to: anxiety, mood, and substance use disorders, which make the presentation and the course treatments more difficult. Lastly, we will discuss the issue of diagnosing in different stages of developmental childhood up to adulthood, and the necessity of the continuum care and the multidisciplinary teamwork. ADHD is one of the most common neurodevelopmental conditions affecting about 5 to 7% of children and 2 to 5% of adults globally, as indicated by Cotis et al. 2025. Historically considered a childhood disorder, but nowadays it's been proved that it can persist among adulthood in most cases, and that the changes in manifestation. The diagnosis of the condition is more frequently in boys than girls, which may be as a result of the overt hyperactivity in males compared to the inattentive presentation in females, which are not disruptive enough and are often overlooked. ADHD disrupts several areas of the life domain: academic performance, occupational stability, and interpersonal relationships, and leads to the loss of quality of life and increased vulnerability to the psychiatric conditions. Comorbidities. The understanding that it is a lifelong process and therefore supports the need to identify early in the presence, maintain a proactive approach, and implement personalized management plans. ADHD involves the neurobiological abnormalities within the dopaminergic and the noradrenergic system that modulates attention and behavioral inhibition, and the activity in observed on the functional image of front striatal and frontoparietal circuit, especially the prefrontal cortex that regulates working memory and executive function. Heritability is projected about 70 to 80% by both twins and family design, which proves that it is highly genetic. Certain risk factors of the environment include prenatal nicotine exposure, lead poisoning, early psychosocial adversities, indicated by an article by Asherson, 2024. A combination of these biological and environmental processes contribute to the shift in the individuals as far as symptoms profile is concerned. The knowledge of these complex neurobiological enables clinicians to develop pharmacological intervention, e.g. stimulant drugs, based on stimulating the neurobiological system of the catecholaminergic pathways to correct underlying neuronal dysregulations. According to the DSM-5, ADHD is characterized by persistent and unending inattention or hyperactivity impulsivity, which impairs the functioning or developmental. Difficulty to maintain concentration, forgetfulness, and disorganized are all symptoms of inattentive domain. These should last through a minimum of 6 months and be inappropriate to developmental stage. Among adults, there are 5 symptoms of the target. More importantly, the symptoms should be reported in at least 2 settings, including home, school, or work, and the symptoms should result in a functional impairment. Considering the compensatory strategies that might emerge in the adult, the clinicians are supposed to check the information with other collateral sources. Proper diagnosis will help avoid the misdiagnosis of normal distractibility as ADHD, and true cases are provided with proper treatment. The hyperactivity impulsivity domain encompasses the fidgeting behavior, interrupting other people, excessive motions, and not thinking before acting. The DSM criteria requires at least 6 months of the existence of the symptoms and impairment in the functionality. Depending on the symmetry of the symptoms, ADHD presentations are classified as predominantly inattentive, mostly hyperactive, impulsive, or a combination of these. An early onset before 12 years old is a diagnostic criterion which differentiates ADHD and acquired attention issues because of neurological or psychiatrically acquired conditions. Acknowledgement of the subtype will guide the treatment as well as psychoeducation, since the inattentive types might be responsive to behavioral intervention differently than hyperactive forms. The manifestation of ADHD varies with the stages of development. At childhood, hyperactivity may be dominant. At adolescence, ADHD is more incapacitating compared to restlessness and inattentive. In adulthood, disarray and inability to manage time takes the center stage. Symptoms might be internalized in girls and thus underdiagnosed and delayed treatment. Symptoms may be clouded by coping strategies, including overcompensating or avoiding over time, though these are usually associated with emotional fatigue. Adults who have not been treated for ADHD often acquire secondary anxiety or even depression as a result of chronic performance difficulties and diminished self-confidence. The developmental lens enhances the clinician to understand presenting changes and enact interventions that will change hand in hand with the person. Differential diagnosis involve the need to distinguish between the symptoms of ADHD and other common psychiatric or medical disorders. Inattention can be imitated by anxiety and depression, either in form of rumination or fatigue. Bipolar disorder has no differences in impulsivity and mood instability, but it exhibits episodic presentations and high mood episodes. Concentration problems may as well be symptomatic of sleep disorders and learning disabilities. The cause should be in form of medical contributors such as thyroid ailments or such as seizures or other ailments, which should be eliminated by way of suitable tests. The assessment of longitudinal data and collateral information collected by parents, teachers, and partners is useful to complement the accuracy of the diagnosis. Such general practice should help avoid overdiagnosing and will facilitate proper targeted management. There is a widespread comorbidities, and they play an important role in the prognosis of ADHD, as strength disorders like oppositional defiant disorder and conduct disorder tend to arise during childhood, which lead to evolution of behavioral problems and conflict with the society. Internalized disorders such as anxiety and depression often develop in adulthood, especially when a person has to live with chronic functional impairment. The occurrence of substance use disorder is also more common, which is why observation of stimulant use should be undertaken. Moreover, the ADHD and autistic spectrum disorders have common type of socio-communicational dysfunction and executive dysfunction, which will be assessed differently. Addressing comorbidities improves treatment adherence and definitely overall outcome. When we think about the pharmacological management, stimulants are still the first-line pharmacological drug treatment for ADHD because the effect and safety has shown to be potent. Methylphenidate and amphetamine derivatives elevate the availability of dopamine and norepinephrine in the prefrontal cortex, enhancing attention and impulse control. The treatment is initiated with a low dose and it is titrated to provide symptom relief with a minimum amount of side effect. Some of the common side effects are the lack of appetite or appetite suppression, insomnia, and slight rises in the blood pressure. Both clinicians should screen cardiovascular risk and observe misuse, particularly among adolescents and young adults. Assistance in compliance and minimization of the risk of diverse involves education and frequent follow-ups. Stimulant agents have a quick absorption and hence they form part and parcel of ADHD. Non-stimulant options are vital to patients who cannot tolerate or respond adequately to stimulants. Atomoxetine is both effective against inattentive and hyperactive and selective norepinephrine reuptake inhibitors and has a lower risk of misuse. Guanfacine and clonidine extended release drugs modify the alpha-2 adrenergic receptors to enhance emotional regulation and decrease hyperarousal, which will be helpful in younger children or in those with comorbid tics. Bupropion is an antidepressant that could be helpful in a person with comorbid mood disorders or risk of substance use. The choice of medication should be influenced by the comorbidities, contraindication, patient preference, which rules out using long-term or short-term decisions and commitment. Psychosocial and behavioral interventions are essential and complementary to the medication and are essential for long-term. CBT is used to teach adults with ADHD how to reconstruct negative thoughts, time management, and organizational abilities. Cognitive performance and emotional stability is optimized by lifestyle changes such as getting enough time sleep, exercising regularly, and daily routines. Adult ADHD is a disorder that is underdiagnosed because of the misconception that it does not manifest itself in adulthood. The symptoms of persistent inattention, impulsivity, and disorganized affect their occupational performances and the relationship of many adults. Emotional dysregulation will look like mood disorders and irritability, frustration, making it hard to diagnose it. Pharmacological therapy is still effective and evidence-based options are stimulants and non-stimulants. Non-compliance might, however, be stigmatized or result in having a high negative history with drug use. CBT and psychoeducation aiming at the skills of coping with adherence involve executive function. The awareness of adult ADHD enhances early intervention, which prevents dysfunction in psychosocial functioning and quality of life. So for the key takeaway, ADHD reflects a neurobiological condition with a behavioral manifestation rather than a purely disciplinary issue. Combination of pharmacological and psychosocial and environmental intervention by early detection and intervention has the greatest long-term outcome. Psychoeducation needs to be employed to reduce stigma and adherences. Definitely continuous treatment of lifelong should involve in accordance with the changing developmental and functional requirements. The effectiveness, integration of the clinician, educators, and the patient's families enhances coordination of care and avoiding relapse. So finally, by comprehending ADHD as a complex disorder, psychiatric professionals will provide evidence-based care. And that is the reference. Thank you for paying attention to this lecture. Again, from Noble Psychiatric Services, we want to wish you the best and hopefully you got to learn something. You're free to comment for a question or compliment to us and we will be glad to respond back. Thanks again for listening to us and you have a good day.